Good afternoon. I am Delaware State Representative Paul Baumbach, serving the 23rd House District, which is the west and north side of Newark. I also serve as the co-vice chair of the Delaware Retirees Healthcare Benefits Advisory Subcommittee, RHBAS. I've been providing these updates during our 6-month activity level. And I wanted to give you an update because an awful lot has occurred this week. So with that, let me start. Actually, let me start on the. Let me start. I want to present it. How about this way? So the SEBC, that's the State Employees Benefit Committee, which makes all decisions regarding healthcare and retirement plans and such for our state employees, met this Monday, the 21st, and I caught it virtually. There was a lot of stuff that didn't interest me all that much, but then this presentation on the Medicare request for proposals, and I'm going to keep using the phrase RFP to describe that. An RFP is when one group, say the state of Delaware, says to some folks, we'd like to do something and we'd like you to bid to provide that service to us, what you would charge and what it would include. And what we're looking for is put into that document called the RFP, the request for proposals. And that is how the state provides its health care for state employees and state retirees, as it says, we want to have this kind of health care. Who out there is interested in providing that to us? So this RFP, we've got a presentation that was made Monday regarding the plan for the Medicare RFP. So that's for retirees who are age 65 and above and qualify for Medicare. So it was sort of going sort of fine. So we see a nice little disclaimer. And it was obvious that DHR's Department of Human Resources raised the need for the SEBC to issue an RFP for Medicare eligible retirees. And these reflect the current direction that DHR is taking in terms of RFP scope and timeline. I want to point out there is no individual who is identified as running this show as I can't say on this slide who created that slide. For this decision on this slide, who made it? We do it. So a little bit frustrating as far as the lack of transparency. So this says, so grandfathered retirees. Here you see on the second line here that they define that as those who retire prior to January 1 of 2025. So what they're saying is we have, as they're viewing it, there are two classes of retirees. There are those who haven't retired as of 2025 and those who retire by December 31st of next year. That's a problem. Well, first thing is I've asked, so when was that decided? By whom? What kind of public meeting? No answers there. Well, I find that a bit of a problem given that we're affecting tens of thousands of retirees and employees. But regardless, they presented this and said what they're calling grandfathered retirees are those who have retired by the end of 2024 and are Medicare eligible. That's therefore eligible for this kind of health benefits. There's still benefits if they retire less than 65 years of age. But that line just set off an alarm bell. They have in here, as far as where they stand, a cutoff between grandfathered where no changes are made and those who aren't grandfathered where changes are being proposed. So alarm bell goes off. The second line also alarmed me. So this scope of service is literally based on feedback from stakeholders. I try to get some more information on this, given that our subcommittee has had public meetings for somewhere around 14 meetings. We've probably had 7 hours of feedback. There hasn't been not a single piece of public comment that we've received saying that Medicare Advantage is good. Every single one points of the problems of Medicare Advantage. So keep that in mind, because supposedly this presentation is literally based on feedback from stakeholders. Well, not from the employees and the retirees that are standing up and speaking up to our subcommittee, but SCBC, whoever that is who's working on this anonymous person at the SCBC, feels that this is based on feedback from stakeholders. Now, they are saying for grandfathered retirees, we're not changing anything. So we're keeping your medic fill, we're keeping the same kind of thing. And I know they before said Medicare Advantage is the same kind of thing as medic fill. And the court said, no, you're wrong there. Stop doing that. But really what I'm talking about, and I think what they're talking about here for their narrow definition of grandfathered retirees, is a Medicare supplement plan that is pretty much based on the Medigap F, Medicare Supplement F, that lets you keep that 80%, all the Medicare network, which is 98% of healthcare providers across the country. You have that, so there's no network you need to go to an in-network or out-of-network doctor. They're all Medicare qualified doctors. And then then there's that gap, that insurance for that top 20%. Currently, the contract is called MedicFill, but this says we're going to keep that kind of coverage, that exact kind of coverage for our retirees, for this part of retirees, those who are retired or have retired by the end of next year, in that same kind of plan. So that, I mean, in one sense, that sounds good. But wait, there's more. Let me. Do I need to worry? No, I won't worry about that right now. Where's my mouse? There's always a question for us. There we go. It must be here someplace. So now, who are the non-grandfathered retirees? Again, based on feedback from stakeholders. Interesting. I wonder who you're talking to. So this is everyone who retires on or after January 1st of 2025. So here, we're going to have a Medicare supplement plan and a Medicare Advantage plan. Oh, there it comes. Really, you got that from stakeholders, feedback from stakeholders, huh? And I love this one. Come down to Medicare Advantage. Prior authorization requirements, I love this, under the Medicare Advantage plan should not be materially more than the Medicare supplement plans. Well, kind of interesting, because Medicare Advantage is based on network and prior authorization, and Medicare supplement plans don't have prior authorization. So how you can have the requested Medicare Advantage plans bid and to have their prior authorization requirements match Medicare supplement, which doesn't have it, is a real head scratcher here. So this slide just plain makes no sense. And then these plan options will also be available to grandfathered retirees. So again, what they're saying very indirectly is, guess what? Medicare Advantage will be provided as an option to grandfathered retirees. Not exactly what you said on the previous slide, but a little smoke and mirrors. Anyway, this is that's slide 4, but wait, there's more. Some of the, again, based on feedback, God, that thing drives me nuts. You can bid on one or both. We'd like to have a high and a low plan. Don't worry about that right now. We'll get to that in a bit. And they should quote a fully insured Medicare Advantage option that's substantially similar in plan designs as the one that we saw last year, starting in June, that Highmark Blue Cross Blue Shield one. And I love this. Again, prior authorization requirements, the second place we're seeing it, should not be materially more than the Medicare supplement plans, which don't have prior authorization. My God, the insanity here is amazing. And they must fully disclose all prior authorization requirements, 2,000 different kinds of services. And I love this. If a bidder can offer Medicare Advantage with no prior authorization requirements and that mirrors CMS requirements under original Medicare, bid should be quoted on that. Well, okay. So you take one of the fundamental pieces of Medicare Advantage, and if you can bid it without that fundamental piece, well, more power to you. This seems to be dreaming. That said, there is an effort the federal government has proposed, not set, but proposed rules that deal with prior authorization, but really it has to do with how quickly they would be required once this gets adopted, if it gets adopted, how quickly they have to turn around a prior authorization and an appeal to a prior authorization. There is certainly pushback for all the prior authorizations that the country's Medicare Advantage plans have. So there is sort of a move to reduce them. But they're still fundamental in there. However, there's a new movement within Medicare Advantage plans to do away with prior authorization, but to have referrals required. And because Medicare Advantage, the other fundamental to it is it has a network. So it's not you go to any doctor who's accepting Medicare and you can go to them. No, they've got a limited network, and that may work if you're a retiree in Delaware. But what if you retire and then move to your sister in Boise, Idaho? Likely, not many of those doctors know much about Highmark Blue Cross Blue Shield of Delaware and its network. So again, the network is the second piece. So this movement of some insurance companies who are offering a Medicare Advantage that doesn't do prior authorization but has a pre-approval is one where if you go and you're in Boise, Idaho, and you have a doctor who's not in the network, and you go and have a procedure, and they say, oh, nope, it doesn't, we aren't covering it. And they don't have to tell you ahead of time. They can tell you that weeks after you have the service. And if they do that, then that entire cost is on you. Keep in mind, Medicare, the first 80% of the cost is on Medicare. And it's just that last 20% that would be that supplement, that Medigap. Well, so in theory, the most you're going to pay, even if you don't have a Medicare supplement, is that 20% of the cost. Here, because it's Medicare Advantage, and Medicare Advantage pulls away traditional Medicare, it's that 80% foundation. Here, if you do not jump through the right hoops on, it's not called prior authorization, it's called pre-approval. If you don't, referral, if you don't do that referral, that pre-approval, you run the risk of owing 100% of the cost there. That's better. Really, it's a shell. I view it as a shell game of terminology. And the same problems that have come up with prior authorization will come up once several companies bring out these Medicare Advantage plans that have renamed what they're doing. They call it referrals instead. Anyway, I love that they're saying, oh yeah, you can quote this even though it doesn't exist. And anyway, don't get me started. On 6, don't worry about that. And this one, this one, all these things pissed me off this week. I'm sorry, I'm on a roll here. So what do I really dislike? This second bullet says that if you're a Delaware retiree using a Medicare supplements plan from the state, and you're using the Part D prescription plan, then there's some money that comes back. It's known as sharing in the revenue. It comes back to the state. Does it go to lower your premiums? Well, sure, but it also goes to lower the premiums of the pre-Medicare participants in state healthcare, and apparently even the employee users of healthcare from the state. So even though this is tied to your plan, the benefits don't stay with your plan. No, it gets spread across tens of thousands of others. Isn't that nice and fair? And then if you go down to the bottom part, is this the one we say? Okay, so they point out that they do not set the premiums to represent what the experience is. In other words, if this group, we've got 3 groups: current employees, retirees under 65 years of age, and Medicare age, therefore 65 plus retirees, 3 different groups. And they say, we don't set the premiums of those 3 groups based on the cost of providing services to those 3 groups. This makes no sense. If this group costs X dollars per person, that's what you should be charging. You don't have these guys paying less than the cost, which is what the Medicare age folks do. I'm sorry, they pay more than the cost, and these other 2 groups get to ride on the coattails of the Medicare age folks. And it says, if we were to remove that, the savings we're doing on the Medicare group, take those savings away from these other 2 groups, the cost for those 2 groups would rise. And so we can't do that. So we're not going to change it. We're just going to leave it unfair. That's what we're going to do. That in and of itself is maddening. But what's infuriating is what they've said is we've got 3 groups: current employees, sub-65 retirees, and 65 plus retirees. This last group is the one that's overpaying. So when we're trying to address this shortfall in funding, where do we start? Let's think. How about the people who are already overpaying? Oh my gosh, tick me off. So at least to put it in writing that they're charging it wrong, and that the Medicare Plus folks are overpaying, and yet that is what our laser focus. The state said we're going to yank your Medicaid and we're going to force you on the Medicare Advantage. You're the group that's overpaying already, and that's who we're going to be focusing on. It's insanity, absolute insanity. So at least it's in writing. At least it came out in a public meeting. Not that the subcommittee raised any questions. I'm sorry, the committee raised any questions, pushed back at all on why is this fair? Why are we doing it this way? We have to change it. But that came out. So anyway, so what they're planning is they've got a grandfather that is really short, a cutoff point that's really short. Those who retire by next year, or nothing changes, and anyone who retires January 1st of 2025 and beyond, who knows what the heck you're going to get. And then they were also doing Medicare Advantage, even though every piece of public feedback was that sucks, please don't do that. So SCBC running this, and it's not SCBC, it's the consultants and the administrators behind it. It's not actually the committee members. They're not speaking up on this, and they need to. When we, the legislature, created Senate Bill 29, passed it, governor signed it, it created the subcommittee I'm on, the RHBAS, but it also changed the makeup, the membership of the SCBC. So we have much better balance in the SCBC than we had that led up to this whole mess. I am hoping that with that new membership, they're going to stand up to this stuff, and we'll be talking about that more. So there's my rant. My rant on SCBC is over. Let's move forward to the RHBAS. Okay, so we had our meeting yesterday from 10 to 1. It ran a little bit late, a little bit long, and it had a whole bunch of things on the agenda. Didn't do a whole lot of that stuff. What did we do? We updated the minutes to say we passed one motion, said no on Medicare Advantage for grandfathered folks, and it noted the 3 members of the administration who voted against it. It didn't note the 11 people who voted for it. I said, no, let's give credit where credit's due. Those people voted on a good thing. Let's get that there. Let's not just point to the 3 who said no to it. So we updated that. I think there was another change like that. And then we started looking at the Medicare. Okay, sorry. Then we had, let's look at discussions and, more importantly, motions about the request for proposal, the SCBC RFP. So we finally, this is 6 months in, we finally are looking at actually taking action on this. We did one motion on August 10th. We had a slew. I created something like 7 or 8 different motions, most of which had to do with the RFP. So let's go and see. God, all that stuff is just, okay, here we go. So here are my motions. And the first one said, there's a lot of whereas clauses. They are important because they point out that we have heard, let me read this last one. Next last one. This subcommittee has received innumerable and well-reasoned public comments unanimously opposed to Medicare Advantage. So while the SCBC claims that this is informed to stakeholder feedback, no, we can measure it. We have the public comments, we have the emails, we have the minutes. We know that the public who has spoken up is unanimously opposed to Medicare Advantage, no matter what the heck the slides from the SCBC currently say. Importantly, move up to the bold, we recommend that Delaware neither request nor consider a Medicare Advantage plan in its request for proposal, RFP. Sorry for the following wording. For medical third-party administrator services and or carrier for providing health care to its eligible retirees in the upcoming cycle. And I expanded that to say eligible current and future retirees in the upcoming cycle. This passed the committee. Yes, it had opposition, had no votes from 4 individuals, including 3 cabinet secretaries who report to the governor. But our subcommittee, which is advisory, said no Medicare Advantage for this upcoming cycle, multi-year cycle for the RFP. And that was the first motion we got done. This is the 3rd motion we've ever gotten done. And we said, let's not stop there. Let's go further. Okay, the next one, frankly, It's sort of important, but it's not critical time. So we passed on that one. Let's go to the third one. The past RFP had placed every member of the SCBC on a proposal review committee. Well, I'm sorry, if you have this body and everyone's on a subcommittee, that's not a subcommittee, that's the body. Okay, if everyone from the SCBC is assigned to this review committee, that's insane. And furthermore, in Senate Bill 29, we made changes to make sure that the SCBC membership was better balanced. Truly stakeholder involved. We have a retiree on there. So the balance mattered, but at the time we hadn't dug into the previous RFP and realized, oh, you know what, that makeup matters also. So in Senate Bill 29, we didn't speak on having balance within the proposal review committee. So I said, well, we want balance. And therefore, the motion I put forward was the PRC for the upcoming RFP should have representatives from these 5 different organizations. One is a cabinet secretary who does, healthcare. Lieutenant Governor's office, she, is chairing the advisory subcommittee. Controller General's office, this is the bipartisan group that serves the House and the Senate, so it has the legislature's interests top of mind. Insurance Commissioner's office is one of the experts, and then one of the union leaders who has a lot of stakeholders in their retired state troopers. So we had that. We expanded that to add the retiree and to add one other. I think it's the Department of the Office of Management and Budget, which is the financial arm of it's a cabinet secretary. So it added 2 people, but it's still designed to be quite balanced. We tabled it because by having a limited list, we're taking some people off. Some people say, well, let's just say you're going to have everyone on there, but if you have everyone on there, at least you have balance. I don't want, personally, I think it's bad for the state, to have an unbalanced PRC. And I don't want, frankly, it set by the co-chairs of the SCBC. So I want it stipulated here. And our recommendation is the SCBC accept this recommendation and have set a balanced PRC. It's on me to reach out to all the members of the SCBC, see if they're interested. We suspect that 1 or 2 may not be interested, and then we want to find from the rest a balanced set of them, and then bring this motion back. So we tabled this motion. That's fine. Okay, next one. This one's very important, and this says the SCBC historically, their practice is they don't vote on the RFP. And I reached out and said, why is that? And they said, well, the RFP, all it is asking for bids. And that's wrong. That is incomplete. In the meeting, I said there's a lie, and I stand by that. I didn't say anyone lied, but if anyone says an RFP is just to solicit bids, they're lying. Because it's more than that. Among other things, it sets the membership of the proposal review committee. It sets how you grade each bid. And by grading it, you figure out which ones make it to the top and become the finalists and are chosen from amongst those finalists. So it not only requests the bids, but it also identifies how you're going to decide which ones make it to the final round. That's way more than asking for bids. That's policy. And the State Employee Benefits Committee, I think, needs to be looking at these policy decisions, and furthermore, needs to be doing it in public. So what we say in this motion is you're going to have a vote in public on the RFP. You're going to share the draft RFP at least a week ahead of time with the public. And you're going to set an agenda that shows when the vote is, very clearly what the vote's on, and you're going to have public comment before the vote. This passed 12 to 3, only 3 people opposed it. Again, the 3 cabinet secretaries. I think, I'm not going to say this is the most important motion we passed. It's really close. I think we passed some great recommendations yesterday, and this is really a very, very important one. The next one, number 5, we didn't find out until Monday in that presentation I showed you before from the SCBC that as currently crafted and presented, the upcoming RFP would only be for a 2-year span with 1 year extension. Well, I look through this and say, do you know how much freaking work we put into this analysis? Again, we've met now for 33 plus hours of meetings. We've had retirees driving up and down the state to attend and to stand up and speak up. And you're saying you're going to go through this again in 2 freaking years? Really? No. The last one was for 3 years with 2 optional extensions. This one should be for 3 years. We passed this too. Again, 12-3. Again, opposed by the cabinet secretaries. Let me say, in the meeting, there was a comment from one of the cabinet secretaries that this is micromanaging the process. My colleague across the aisle, but my Greater Newark area colleague, Representative Mike Ramone, who's the House Minority Leader, I want to thank him, and I have thanked him. He spoke up and he said, he may not have said I'm offended. He might have said it because I take offense at talking about micromanaging. This process was screwed up. Don't take my word for it. There's a court order telling you to stop doing it because you screwed it up. And to say we're micromanaging, well, yes, we are. You know why? Because you screwed up. And we're trying to make sure you don't screw up again. And if you hadn't screwed up, criticize me for micromanaging you. But you did. So you don't get to criticize me. You can vote no. That's fine. You got 12 other people that think this is the right thing to do. Sorry, still getting fired up. Let me say, after yesterday, I was so keyed up leading up to yesterday's meeting, and through yesterday's meeting at the end, I felt like I could finally breathe. Yes, I'm getting a little worked up, but I'm getting worked up knowing there's a celebration at the end. So, you can, we skip the next one. Actually, 1, 2, 3. Those are all of my motions that we got to. But a committee member, former State Representative Bill Oberle, presented a motion very similar to motion, well, really to motion 6. What he said is any changes, he sets with the grandfather date, not retired before 2025, but rather hired before 2025. So it says every employee will have the same health care as current retirees. So we're grandfathering not only all current retirees, not only those who retire in the next year and 3 months, but we're going to grandfather all employees also who have been hired by the end of next year. And that way it says when you sign to say, I accept this job, you will get the health benefits that were in place when you signed that form. And we can't change it during your term of employment. I was surprised, but this passed. We had 9 yes votes and 6 no votes. Former Representative Bill Oberle did a great job. He also, Jeff Tashner from DSEA and others joined him in this effort, and they were successful. So we got our recommendation, and all our recommendations, we'll come back to that. Our recommendations were to get Medicare Advantage out of the RFP for the next 3 years, out through 2025, 6, and 7. So go from 2 years to 3 years, get Medicare Advantage out of there, have the RFP, not something that's done in a smoke-filled room, done in a public meeting of the State Employee Benefit Committee, voted upon in public after having public comment, and after the public has had a week to review it in order to prepare their comments. And the grandfathering is only for people who are hired after 2024. 4 important motions, got them all done, and we have more work to do. That was what we accomplished on yesterday. I want to thank everyone who stood up and spoke up. This was a massive amount of work of a massive number of people who stood up and said, you can fight City Hall. You can fight an administration who's trying to take away your Medicare supplement. And thank you. Now let's talk about what for non-grandfathered people. So this is new hires. what are we picturing for what healthcare we're providing to them? What changes are we proposing for those who aren't grandfathered? And maybe even what options we're going to provide to those who are grandfathered, but we're still going to give them as the basic at the same cost at 5% of premium. You get a Medicare supplement like Medicare. But maybe we'll give you another choice. And there's some reasons. We'll get to that in a minute. We have studied an alphabet soup of different Medicare supplements. We've looked at F and G and L and N, maybe a fifth one in there someplace. And we've had different, are we going to charge 15% or 30%? We're going to buy up from one level to the next level. I raised in the committee that it was insane that we were doing that. And I'm sorry, we also have all these comments. I want to go through some of these silly slides. So it's good. Think of this as, this is either a footnote or this is a appendix, okay? We are not looking to do all these things, but we want to know if we did this, what the impact is. We've got slide after slide of what the cost and savings are of various things. And then we've got slides after slides of combos. Okay, well, if you do this piece and that piece, and this piece and that piece, then this is the dollar change and we'll get this far. That's wrong. And it took me a while to realize that is, in hindsight, it's a stupid approach. Okay. Instead, let me see if I can get there. Nope, I'm going to get mine. There we go. Get this. Okay, we'll go to mine here. So this is what current retirees and grandfathered current and future retirees pay. The average person, the premium, which again is inflated by the state, it doesn't cost $3,125 for the medical portion of that. It does not. The SCDC has admitted that on that slide. Okay, but they're charging that $5,500 total. Of that $5,500, $5,236, or 95% of that is paid by the state. Okay, it's called $5,200. Okay, so the retiree pays 5%, about $276, and the average, the 50th percentile, the average participant doesn't have any medical costs that they have to pay out of pocket. They do have almost $400 worth of out-of-pocket prescription drug costs. So their total annual cost is around $650. If you're on the healthier side, you still have to pay that $276. Your prescription drugs are about half as much. So you're only paying about $470. And if you're on the sicker end, so if you have higher cost than 90% of other retirees covered by this, you're paying about $800 a year. So $470, $660, $800. Let's say $450 to $800. Okay, with the average, actually, let's just look at the average right now, $650. The state's paying $5,200. The average retiree is paying about $650, $660 out of pocket in a year. Okay, grandfather, we're not touching that. If you're not grandfathered, what alphabet soup should we give you? And the answer is, well, it depends. How much are we willing to charge a non-grandfathered retiree? Their grandfathered ones are paying $659 a year. Should we be charging them $859 a year? Should we be charging them $3,000 a year? What do we want? What are our values? Yes, we can say this is too generous to provide forever because we have an $8 billion hole. So it's quite appropriate to say, let's consider changes, and also let's consider who's not being affected by these changes. So we've made that recommendation as far as who's not affected by it. But for what we're changing, before we get to the details of what it is, let's first look at the dollars. You know I'm a numbers guy. How much are we willing to have employees pay more? And how much do we want to save the state? Oh, shoot. I don't have it up there. Let's do that part. There you go. I'm sorry. I'm talking about numbers I'm looking at and you're not looking at. So actually, let's do that way. There you go. You can see it. So the average retiree is paying $659 a year under Medicare, under the current system for prescription drugs and for the medical coverage. If you're less healthy, maybe $800 a year. If you're more healthy, less than $500 a year. But the average one's paying $659. What do we think that a non-grandfathered one should have the out-of-pocket raised to? Should it be twice, 3 times, 4 times? Should it be $300 more? How much less should the state be paying? Should it only be $500? Should it only $5,000? Should it only be $4,500? Whatever. Well, I'll tell you what. let's go and see what one of the projections is. And so this is one where they look at, here's the alphabet. Medic-Fill on the far left here, right? L, think of that as low, it's the least expensive. N is a medium one. If you look at the premium charges that are being proposed, Medic-Fill costs $31.25 currently. Medigap L is about $1,000 a year less, $2,100. Medigap is $2,750, so it's maybe 2/3 of the way towards Medic-Fill. But let's go to the 50th percentile and say, what's the average person paying? The average person paying it. You know what? Something else I didn't mention. It was run this way. We ran it. We permitted it to be run this way. The default is the Medigap L. The smallest premium you're going to pay is 15%. 15% of the cost. If you want N, which provides better coverage, you pay 25% of that cost. If you want the Medic-Fill, you have to pay 30% of the cost. So what out of pocket are they paying? If the average person is paying between $1,400 and $2,000 a year, what was it under Medic-Fill? $659. So we're tripling it here. More than doubling it if they happen to choose L, tripling it if they're choosing N, and even more if they're paying up for a Medic-Fill. And the state cost goes from $5,400 to $3,800, a savings of $1,400. That's more than 25%, I believe, of lower cost. And that may be what I don't speak for the subcommittee. I'm one person out of 15 on the subcommittee. The subcommittee, I feel, needs to decide these two things. How much are we willing to have the out-of-pocket cost for non-grandfathered retirees rise to, and how much savings do we want? How much do we want the state's cost to go down per retiree per year? With those answers, we can then figure out what alphabet soup Medigap to put in here and what percentage share the retiree has. Until we do that, until we decide how much we're willing to have retired employees pay out of pocket if they're not grandfathered, and how much do we want the state to save and have to pay each year for these non-grandfathered retirees, it's ludicrous to spend any time on these individual policies, doing any more running of models, and especially doing combinations of this and something else. The cart is before the horse, is ahead of the horse. That doesn't serve anyone other than wasting time. So I've asked the subcommittee to please give thought, and I'm hoping that at the next meeting on September 8th, we answer how much are we willing these numbers to be higher than what they are for current retirees, and how much lower do we want this number to be than what it currently is for the state share. With that, we can quickly identify what the percent will be, how much of that cost to the retiree will come from the percent share of the premium, and how much will come from the out-of-pocket costs based on how much the plan covers and doesn't cover. So, okay, I know numbers, and I apologize for that, but sort of felt like I sort of had to. That's all I wanted to talk in advance. I see I've got a few people on, so just in case there's some questions. Andrea, thanks for all you're doing. Check out Rise for all the thank yous you received. I have already received several thank yous in my email box today, and I truly appreciate it. I will say that I had easily over 150 emails in less than a week from retirees in advance of Thursday's meeting saying, please, no Medicare Advantage. And that took time out of people's lives, and I want to thank you for that. We had probably in the order of 50 or so retirees show up yesterday, and that mattered. They spoke after all the votes, but they were good votes. So I think what happened is all of that public comment from before was already in the subcommittee members' heads when they were deciding how they were going to vote. So thank you for your emails. Thank you for your outreach. Thank you for your presence. Thank you for your time. Okay, so Andrea said the concern is the SCBC is going to do what they want anyway. Andrea, I agree that is the concern. Frankly, that was the concern when Senator Townsend and others created Senate Bill 29. I was also one of the prime co-sponsors, but it was initially his bill. And, it was not only creating RHBAS, it was also reforming the membership of the SCBC. It is far more balanced now than it was last year. And we have what I hope is that if you care about this, and clearly you do, reach out to the SABC members. Raise your concerns. Raise your concerns about Medicare Advantage. Raise your concerns about doing business in smoke-filled rooms versus doing them openly, voting in public, listening to the public. Accept our recommendations. And part of that is reject the administration telling you, an SABC member, that you should not have a say in what goes into the RFP. The term, what kind of plans are being bid, how you're rating them, how you're going to be choosing who the finalists are, who's on that committee to decide the finalists. Make sure the public gets to see it in advance. Make sure the public gets to speak up about it in advance and do the vote in public. I think the SABC can rise to our hopes. Clearly, yesterday, the RHBAS rose to people's hopes of what it could do. Stop being a rubber stamp for bad policy. The SABC has the potential. I hope they live up to their potential. What you do can affect that, can increase the chances that they will live up to their potential. And Henry, I post this publicly. You can post it wherever you want. Thank you for asking. I am, given how I've been bombarded over the past 6 months, I'm looking forward to someone else getting bombarded for a while. No, seriously, listen, the SABC members serve the public. They serve the stakeholders. And I don't mean the insurance company executives. I mean the state employees and the state retirees. And it is quite appropriate for them to hear from the stakeholders, from the true stakeholders, not the ones claimed in that stupid presentation, but from Delaware's employees and Delaware's retirees and beneficiaries, spouses, etc. The action from the citizens got results yesterday. We need it to keep going through this RFP and then through the award of the contract, hopefully for Medicare supplement plans that should come up in the winter, early spring. And for the plan that's announced in June with presentations in August to September, and that enrollment happens October, November, and it starts the following January. We are looking for no Medicare Advantage. We are looking for everyone who started work at the state before next December 31st being covered the same with the default of Medicare supplement FG, which is what Medicare is. I do want to mention, even though that's the best, if that's the default at 5% for grandfathered folks, you may still want to have some choices in there. That is to help retirees who don't have enough years of service and they have to pay more than that 5%, 50%, 75%, 100%, because they have much fewer years at the state. If we have a less expensive plan like Medigap L and they have to pay 50%, they have to pay, therefore, of the medical part, 50%, they have to pay, we'll call it $1,100 instead of $1,600. So they're saving $400 a year. And if they're healthy, that may really work out well. So having other choices in there, as I like to say, it is good to have choices if the choices are good. A Medicare supplement that uses 80% of the base being traditional Medicare with a supplement above it, to me, is a good choice. Today, to me, Medicare Advantage is a bad choice. Offering some of these lower cost Medicare supplement plans to grandfathered retirees really is designed to primarily help those who would have to pay more than 5% of the premium. It also, frankly, would help those who are extremely healthy and they want their 5% to be less because, instead of it being, you can't see what 5% is of these guys, but it would be 5% would be $150 here and it would be only $100 there. So $50 savings. Having more choices in there is designed for those who don't have the state covering 95% of the premium. That's downstream. The next thing I want to see is to have us figure out how much are we willing to have non-grandfathered future employees, non-grandfathered retirees, way in the future? How much are we willing to have them spend out of pocket in today's dollars? And how much do we need to save per non-grandfathered retiree in the future per year to the state? With that, we can figure out what plans put together, and then we can start going into the combos. All the slides of combos and all that stuff, that's input. That is not something you need to worry about right now. We did stuff we needed to. Right now, we have the pieces that once we get those two answers, we can then choose from all the analysis we have. I used the phrase yesterday of paralysis by analysis. Wayne Emsley, who is a wonderful subcommittee member, he always sits on my left side, has been pushing from day one to get Medicare Advantage out of the mix. He's collected all the handouts. He's got this binder that's several inches thick. And I was going to lift it up and say, do we really need Wayne to have a second binder now? I mean, do we need more analysis? We do not need more. We've got a whole bunch of analysis. We've got all the numbers we need. We really do. Once we take all those numbers and say, here are the 4 elements that we're going to change for non-grandfathered retirees. Now let's model it and see how far along we get. And I spoke up through a chat at the SCBC meeting. We chose 80% as our goal of getting the funding ratio, having the assets get up to 80% of what the cost of the promises are, right? And at the SBC meeting, one of the cabinet secretaries said, well, we'd like it to be a lot higher. The pension things, 93%. Keep in mind, 3 populations: employees, younger retirees, less younger retirees, sub 65, 65 plus, okay? We are only, now, the employees are covered elsewhere. They're covered, it's not OPEB because this trust fund is only for retiree benefits. So it doesn't cover current retirees, current employees. So there's really only 2 groups there. We've got the younger and the less younger. We're aiming to get to 80% using funding, that's money from the budget, and changes to the benefits to the 65 plus. That's what we're doing. That's what we're talking about here, as far as what kind of Medigap plan to offer to non-grandfathered retirees at what cost. So we'll do it. We've got the funding that gets us up to 60% in and of itself, and we've already put those steps in motion. There's additional steps we can look at. We're looking to make some benefit changes, some reducing the benefits or charging more for non-grandfathered retirees. So we do a little bit more to get us up to 80%. Then we need to start working on this population and say, hey, what are we doing here? Because they cost 3 times as much as what health benefits for a Medicare age person does. Why? Because once you're 65, this plan that you've paid into for 40 plus years, you've been paying into Medicare with every paycheck from the day you started working, okay? You've been paying into it for decades, and you're still paying it. You're paying the premium. I think it's $150 or something. I think it's a month. I'm not there yet, so I don't know the number. But you've been paying it all your working life. You're paying it now, and it covers 80% of your costs. So the cost of the state is not much. It's way bigger for the sub 65 retirees. There's some savings to be done there. We got to figure out what our grandfathering is. Sure, absolutely. But we got to make some changes there. And that'll get us, if we get to 80% just with the funding plus some benefit changes for non-grandfathered Medicare age folks, make some changes to the non-grandfathered, non-Medicare folks, that can get us above 80%, maybe 85, 90. That's more than enough. More than enough. We got a plan. I have a plan. I think we got a plan. We can do this. We've made great progress this week. We've got some, we keep talking about this October 1st report, final report. There's no way in the world that we're going to have a final report on October 1st. There's way too much work to be done. All we're doing is we're working on one population. We got way more work to do. It'll be an interim report. You heard it from me. Okay. Thank you once again. Yep. And there's crickets on your video. Those are crickets, or they're locusts, or there's something or other. My window's open. I've got some woods behind me. And indeed, they've been hanging on every word I've said. Listen, I hope that you have a wonderful weekend. I hope that you, like I, are relaxing, feeling more relaxed because of the action of my subcommittee members yesterday, who listened to you. over the weeks and months that you have been working so hard to make sure we understand the problems of Medicare Advantage and your very firm convictions that we will not do that. So please have a good weekend. I probably won't reach out do another one of these until the weekend after the next meeting on September 8th, so that whatever that weekend is, the 10th, 11th, something like that. Have a good Labor Day, and I will be talking to you. I'll be posting this on YouTube as always. Thank you again.